we've reassessed the independent contribution of lithium. And this is one of those studies. They looked at individuals in their early 40s who were starting de novo a medication for bipolar disorder. They followed them for a couple of years with a range. They looked at changes in GFR over time in people who were on lithium or the comparators. Who are the comparators? Quetiapine, olanzapine, and valproate. After they adjusted for demographic factors such as age, medical comorbidities, and of course baseline renal function, and episodes of supratherapeutic lithium levels, they found that the mean annual change attributable to lithium was about 1 ml per minute compared to 0.4 mLs per minute for a comparator. So you can do the math. The difference was 0.6 mLs per minute per year. This difference was not statistically significant. That attributable to lithium alone, you can see, was really a fraction of an ml per minute per year. I'm not saying that lithium does not have renal adverse effects. It certainly can, but once we appreciate that some of what we were blaming on lithium had to do with the patients we were treating, it's called confounding bias, we now realize that maybe when we use lithium the right way, it's not as bad as what we thought. Now you're thinking, what does he mean the right way? Well, I'll tell you what the right way is. The right way is to prescribe it once a day. We now understand, and we knew about this for over 40 years. Mo Shu published a paper in 1982, which I was shown when I was in training, showing that people at 2 different clinics in Denmark, one who gave lithium twice a day, one who used it once a day, had differences in renal outcomes noted as a difference in polyuria risk. And guess which one was better? It was giving lithium once a day. Here's a modern study, though, which really cements that hypothesis. Large database study, all these human beings were on lithium. They took 1,445 people who had renal insufficiency, defined as a GFR below 60 or ICD code, and they matched them 1 to 3 with lithium-exposed peers who did not have renal insufficiency. It's your classic case control design. And they looked at all the factors which might contribute to why certain lithium-treated patients had renal insufficiency while others did not. Look at what they found. Once daily dosing of lithium was protective. You can see the odds ratio here. There is no viable reason to give any human being lithium who's an adult more than once a day. I don't treat children. They have super duper renal function. Pre-adolescents may need lithium administered more than once a day. I accept that. But once they become adult size, and certainly adults by age, lithium should only be given once daily, always at bedtime. And the reason at bedtime is that we want to get 12-hour levels to make all of our decisions. Lithium in the adult brain has a half-life of 28 to 48 hours. There was never really a therapeutic reason to do it, but because sometimes people get some GI side effects, it was just the culture. It was the history in the 60s and 70s to give lithium multiple times per day. We now know that this is, and I will say it, wrong. There was never a reason to do it. Lithium has an extended half-life in the brain. Lithium should only be given once a day. It's much easier on the kidneys. And of course, be mindful of the 12-hour levels. When I trained, I was taught that a therapeutic range of lithium might extend to 1.2. That's wrong. That's now wrong. Certainly for maintenance, the sweet spot we now say, and this is true in really all algorithms out there, is a 12-hour level based on single daily night dosing of 0.6 to 0.8. Yes, there is some accrued risk compared to people with levels below 0.6, but that's the sweet spot. You can go up to 1 as necessary, but never above 1 as a maintenance level.